All right, we're going to do this one live. So, welcome back to the next edition of Dr. Twyman's Ask Me Anything. We're going to answer your questions about lipids, atherosclerosis, biohacking, mitochondria, whatever you're interested in. So, we got a few questions submitted ahead of time tonight. We're going to answer them for you. If you have any other comments or questions, just drop them in the comments and happy to answer them. So, first question up tonight is, does a combination of nattokinase and it says Lipitor OX. I don't know if this is the Lipitor OX from Orthomolecular, or you're actually meaning Lipitor as in atorvastatin. How does it reduce plaque in the arteries? Well, if you're lowering lipoproteins with anything, you're going to lower the risk for further deposition of cholesterol into the artery walls. But if it's just the one that has an effect on decreasing oxidative stress, it probably doesn't have much effect on the plaque in the arteries. Nattokinase is more important for lowering fibrin, so it helps the blood not clot. It's an antioxidant. May have some benefit at lowering lipoproteins. I haven't seen any significant reductions in it, so I don't use nattokinase for lipoproteins. It's just mainly if people have high fibrinogen on blood work. All right. Next question up tonight. Person says that they're on a statin. Their calcium score is 700, so anything over 400 is considered high risk. The carotid scan is okay. If their stress test is good, do I need any other test? Which one? Well, I always recommend doing a combination of biophysical and biochemical. So, you have a high risk calcium score, but no reported ischemia on a stress test. So you don't necessarily have to do any other atherosclerotic assessments. If you have the capacity to do it, a clearly CT angiogram might be a good one because then it would look at the plaque characteristics to see, we suspected to have calcium in the walls of the artery, the calcium score of 700, but how much soft plaque and how much necrotic low density plaque do you still have in the artery? So that's the thing, is that if you live long enough, you probably develop plaque in the artery, but the goal is not to have a heart attack or die from vascular disease. And it clearly can tell you, have you already kind of stabilized all the plaque? There are other tests that can look at endothelial function. That's where like an endopat scan would come into play. That would tell you, have you basically improved the force field? Do you basically have a healthy glycocalyx, healthy nitric oxide levels? Then you're less likely to develop further plaque in the arteries. And then other tests, other than that, would be biochemical. So that's where you could do a comprehensive Boston Heart Lab or Cleveland Heart Lab panel to figure out why you develop such high degree of plaque in the arteries. All right. Good question tonight about mouth taping. Can mouth taping during sleep help to increase nitric oxide? Potentially, yes. If you breathe nasally, you can improve nitric oxide because of the nitrate-reducing bacteria in the sinuses. I would recommend mouth taping during the day first to see, can you tolerate it. I've tried a few times with meditation and no problems, but sometimes I've used the mouth tape, try to sleep through the night and wake up by pulling it off. So try it during the daytime first. Make sure you can breathe comfortably through both nares before trying to do it for real while sleeping. But nasal breathing definitely can be useful for improving nitric oxide. What are my thoughts on PQQ for mitochondrial health? I think it's an interesting supplement. It can improve mitochondrial biogenesis, so it can grow new mitochondria. It's an antioxidant. It can help with energy production inside the mitochondria. So interesting supplement. A couple different manufacturers of it. So you have to kind of follow their dosing directions if you're interested in those. Rapid fire tonight. So a healthy 30-year-old who just got a vaccine for the COVID-19 virus. Should there be anything to worry about? Well, it depends on what your baseline health truly is. Do you have no evidence of high blood pressure, no evidence of diabetes, you have a vitamin D level of 60, you have a good VO2 max? Is that the type of health that you're speaking of? Then probably relatively low risk. But at this stage of the game, what are you doing the vaccines for is really the question. For prevention of ending up in ICU, probably not useful. The virus is mutated enough where it's not that virulent anymore. So that has to be a good reason why somebody should continually get a vaccine. The biggest concern is that the spike proteins can damage the endothelial glycocalyx, and then that can contribute to stiffer arteries, raising blood pressure, increase the risk of clotting. So that's how the virus damaged the microcirculation, but also potentially the spike proteins from the vaccine could. In younger individuals, could increase the risk of myocarditis, which is inflammation in the heart muscle. So you need to talk to your doctors who are recommending the vaccine, why they're recommending it to you. Question, is it possible to lower blood pressure by 10 points or more without drugs? Absolutely. Exercise is the best drug to lower blood pressure by that degree. Doing things like heart math. You could do the respirate device. You could do the Zona Plus device. Those have been all shown to lower blood pressure without using drugs. There are other nitric oxide promoting supplements, either lozenges or capsules that can lower blood pressure in the neighborhood of 10 points without drugs. Sauna probably would help long term, lower it by that much as well. But yes, you want to have your blood pressure 120/80 without medications optimally, or less. What causes an aortic dissection? This just happened to somebody who was an avid running friend of the person asking the question. So it's going to depend a little bit if it's a thoracic or an abdominal aortic dissection. The thoracic ones are more scary, honestly, because they can tear into the carotid arteries and cause a stroke. They can tear down into the coronary arteries, cause a heart attack, or they can just tear enough where the person will have basically event where the aorta will then bleed out and they will have rapid death, essentially. More common in patients who are smokers, more common in patients who have uncontrolled hypertension. There are some family histories where people will have them, and they'll have probably an issue with some connective tissue disorder. There's an Ehlers-Danlos form that can increase the risk of aortic dissection. I will often check a gene called KIF6. Those patients have increased risk of aortic dissection. So if you have any of those risk factors, then you need an echocardiogram and potentially a MRI or CT of the chest to look for aortic dilation. If your aorta is dilated, then it's much more risky that the aorta will eventually dissect. And basically, dissection is when the lining of the artery in the intima tears away as blood gets behind the lining of the artery. A 64-year-old woman with no family history for coronary disease, non-smoker, cholesterol 160, LDL-C 80, goal ApoB question mark. So LDL-C and ApoB generally track together in people who are not diabetic, but without knowing do you have plaque in your arteries, it's really hard to say exactly what your ApoB target would be. If you have a calcium score that's 0 at an age of 64, then your ApoB target's probably around 70, or if your ApoB is nearly 100, that's the 50th percentile. Maybe you don't need to be as aggressive if you're not laying down significant plaque. But if your goal is to live to 90, 100 years old, then you generally want your LDL cholesterol to be less than 70, and probably an ApoB under 70 as well. If you have a calcium score over 400, then probably an ApoB target less than 55. Does pomegranate juice help lower cholesterol? Potentially, but typically think about pomegranate juice more in the fact of lowering HDL dysfunction. It can decrease oxidative stress. So we think about it for that reason. But one challenge with pomegranate juice is how much sugar would come with it. So you got to make sure that you're doing enough resistance training, that you don't have issues with insulin resistance, because anytime you drink juices, you're going to have a big insulin response. So, you can do pomegranate seeds. That would be something to consider if somebody really has issues with their blood sugar regulation. Next question up, is it safe to take berberine and aged garlic while taking Zetia? This is educational only. This can't be direct medical advice for people, but I'll just walk you through kind of how the mechanism actions are. But in general, there's no supplement interactions, and I do have many patients on this type of combination. So berberine acts as a oral PCSK9 inhibitor, so it's going to help lower lipoproteins. It also acts similar to metformin to help keep your blood sugar under control. The Kylo-aged garlic helps with plaque stabilization, can help the plaques from being vulnerable to being more stable, can lower oxidative stress, may have some effect on lowering the lipoproteins. And then Zetia, or ezetimibe is the generic name, can help with preventing cholesterol reabsorption from the gut. Cholesterol leaves the body through the GI system. So berberine would be basically, I use the analogy, think of water flowing into a bathtub. To prevent that water from overflowing the bathtub, consider the water cholesterol. You can do one of three things. You could shut the faucet off. That would be, if you're a hyperproducer of sterols, that'd be like using statins or bempedoic acid to do that. Berberine would help basically open up the drain, so the water would drain out of the bathtub. And then once the water's out of the bathtub, it gets into the sewer. Got to make sure that it actually goes out to the street. Ezetimibe makes sure that happens. So ezetimibe makes sure that the water doesn't back up into the bathtub. So, long-winded answer. Can't tell you directly if there's a problem for yourself. You only know and the person who recommended that you be on that. But in general, those are generally okay to be taken together. Next question. Total cholesterol elevated at 296, LDL cholesterol elevated at 210, ApoB 141, non-HDL, I don't know if it says ratio, 232. Other biomarkers good. Am I in danger? From an ApoB at the 99th percentile, very much potentially. Now that is the pattern of familial hyperlipidemia, but you can also see it in the patients who identify as lean mass hyperresponders. I think that's kind of a wastebasket term. I don't think we know everything about how lipids are metabolized, but the longer your ApoB is elevated, the more likely your glycocalyx will be impacted by those lipoproteins. So if it's a transient, maybe not an issue, but if this has been your pattern for 45 years, much more likely to develop plaque in the arteries than somebody who is in the 20th percentile. So when I see this type of pattern, a calcium score alone probably wouldn't give me much idea that you're at low risk. I mean, if your score is 0, okay, great. But you'd want to know if you have a lot of soft plaque in the arteries with this type of panel. So a CT angiogram, ideally with clearly analysis, will give you that idea. If you have a lot of vulnerable plaque building up in the arteries with this type of lipid panel, you can look at different markers in blood, looking at the cholesterol balance test to see are you a hyperproducer of sterols, you're a hyperabsorber of sterols. Genetically are an ApoE4 carrier. If you're an ApoE4 carrier and you're eating a higher saturated fat diet, you'll often see this type of lipid profile. So are you in danger? Possibly. I tell people, I'm from Missouri. You got to show me. So do the testing to see that your arteries are not impacted by this. If your arteries are impacted, where you have evidence of endothelial dysfunction or vascular inflammation, then you'll probably want to do some type of nutritional change, potential nutraceuticals, but this is the type of range that if you couldn't get it down with lifestyle within 3 to 4 months, you really should potentially consider pharmacological therapies to lower your lifetime risk of vascular disease. All right, so I'd have to do a little bit of research on this. I mean, which statin studies best illustrate their effectiveness that are not sponsored by pharma? That's something I would not know off the top of my head. I mean, almost every trial is going to have some sponsor. And so that isn't always the biggest takeaway is who sponsored it. Yes, it matters to know who sponsored it, but it's more important to know who are the principal investigators, what other trials have they done, what are their biases. Think about it that statins are tools. That's what I've been saying for 22 years as a physician. If you can't tolerate statin, okay, there's other options. If you just prefer, I don't want to take a statin because I'm concerned about the side effects, there's other options. You just want to keep your arteries as healthy as possible. If you live long enough, you're likely to develop atherosclerosis. And statins are one tools that can help stabilize plaque if it's present. So I'd have to do a little bit of research to figure out which studies that would not have any pharmacological sponsorship. I'll have to do some research first for that. What foods can help clear the arteries without plaque chipping off, causing blockage? So I'll take the second part first. Plaque doesn't necessarily chip off. It's more that the plaque ruptures. So think of it more like a pimple in the wall of the artery and it pops. And then the damaged cholesterol white blood cells and other cellular debris spills out to the bloodstream, and then the blood clots and blocks all the oxygen nutrients from downstream. Now, what foods can help clear the arteries? It's not necessarily that it's going to clear it. It's more that you stop doing damage to the glycocalyx. So, you don't want to have high glycemic load foods where you're having huge insulin responses. You don't want to have trans fats in your diet. You don't want to have a significant overbalance of omega-6s to omega-3s. So omega-3s are mostly cold water fish. But nutrition has a role, but it's not even the biggest lever, really. It's more about doing things that improve your ability to recover from the damages. So, what is your heart rate variability? What is your sleep quality like? What is your exercise? Those are going to have bigger levers if you're going to develop plaque more than your diet would be. Not saying diet's not important, but it's not the most important thing by far. Another question about lipids. So my total cholesterol is 155, their HDL is 68, LDL cholesterol is 74, and they're 30 years old who lives, quote, a healthy lifestyle. Are there any other tests worth pursuing? So at 30 years old, a couple things to consider. Based off your traditional lipid panel, it'd be less likely that you're going to have lipoprotein A, because often LPLA, will give you a falsely elevated LDL-C. But LPA should be checked in everybody at least once and see if you have high levels, because if you have high LPA, it doubles your risk of having a stroke. But what else would I consider? I would do testing that looks at endothelial function. I would look at an endopath scan. We'd look at blood pressure, central blood pressure, potentially look at pulse wave velocity. There's devices that we have in our office called the Max Pulse. I'm demoing out the Oura Gen 3. I had the Oura Gen 1 when it came off Kickstarter, and it looked like a big mood ring. Haven't used them for a couple of years. The battery in my Gen 2 died, but a couple of weeks ago they came out with a new feature where the ring will be able to assess your basically an arterial age and also your VO2 max, but you need 14 days of data on it before it'll give you that score, so I'm only like day 6, 7 into it. But those are things I would look at, is like how elastic the arteries are. Are your arteries making good nitric oxide levels? You can do oral nitric oxide test strips to see if you're making good nitric oxide. Those would be starting points. And then typically, age 35 or so, we'll consider doing something like a CIMT scan, looking at the carotid arteries, looking at if there's vascular inflammation. If you have a family history, then maybe you would consider doing a calcium score or a clearly scan at 35. Otherwise, potentially at 40 years old, you start those type of imaging tests to actually look at the arteries directly. All right. So rapid fire style tonight. Got through the pre-submit questions. I know a lot of good questions coming in through the comments. I see them as they're going through, so we'll hit some of those ones. How to lower small dense LDL particle count. Typically, they're going to be elevated in patients with insulin resistance, or to prediabetes. So, reverse that if that's the case. If they're always small, there is some genetic predisposition to making them small, so you might not be able to come around that. But eating more omega-3s, so seafood may have an effect. Those are probably the biggest drivers for insulin resistance and low omega-3 intake. What test would I recommend for a healthy 52-year-old woman with no known heart issues, wants to be proactive about heart health? Only family history is mom has heart rhythm issue, atrial fibrillation. So at that stage, I would recommend a CT coronary calcium score. If your calcium score is 0, you're low risk. If your score is over 400, high risk. Over 1,000, very high risk. Then that determines what other tests to consider from there. If you're very proactive, I have patients come in and see me in my office. I have about 40% of my patients flying into St. Louis to see us to get these type of tests that I'm talking about tonight. Those are the tests where you're looking at endothelial function, like an endopath scan, the Max Pulse looking at pulse wave velocity. We do carotid intimomedial thickness scans in our office to tell you your vascular age. We do abdominal aortic aneurysm scans to make sure you don't have an aortic aneurysm that would put you at increased risk of dissection. We do smart ABIs, so ankle brachial index, to look at the blood pressures in your legs to see would you likely have blockages in your femoral or popliteal arteries feeding blood to your legs. because atherosclerosis is a systemic process. You have 60,000 miles of blood vessels, so you need to go looking for those. And then we also have testing that can do central blood pressures, and if you need it, a 24-hour blood pressure monitor. So it depends on how deep down the rabbit hole you want to go looking for vascular health. But if you want to start with something, start with a calcium score. What do I think of FFR CT scan? Honestly, I don't think the data is that clear that it's that useful. I used to be an invasive cardiologist for many years, and there's a procedure called fractional flow reserve. So if we observed a severe blockage in the artery, but we were on the borderline to think like, well, would this person likely benefit from a stent? Our colleagues would place a wire past the obstruction, would induce hyperemia with adenosine, and then they would measure basically the blood pressure past the blockage and the blood pressure before the blockage. And if that ratio was less than 0.8, then it was a significant stenosis, and then a stent would likely be deployed in that case. Now there's CT scans that can purport that it can measure FFR non-invasively. I don't know if the correlation is that great. I personally don't utilize it in any of my patients. Stenosis is important to know about, if you're having symptoms, if you're having chest pain, is it likely that causing it? But plaque is what causes heart attacks. And so you don't need to know about the FFR in the majority of people. You need to know how much plaque are in the arteries. So the workhorses for that is a CT coronary calcium scan or a CT coronary angiogram with contrast. And then you could potentially use that image, send it off for the clearly analysis, and then know how much soft plaque you have in the arterial wall. More plaque, more risk for arterial events. Do statins reduce small dense LDL? Not always. It's more that they lower the total number of particles. All right, question. Where do I get my blue blocking glasses? I've been wearing various vendors since 2017 when I first discovered circadian biology and how it affects jet lag. And so, these particular brands, these are the EMR Tech Wolverines. I just like the style of these ones. If you want to know more of the vendors I usually recommend, because I've either tried them, I have a website, just drtwyman.com. There's a link on the website that goes to the different vendors with the blue blocking glasses. This question, can I discuss berberine versus dihydroberberine? I've not seen data that dihydroberberine has the same effect on lipoproteins. Maybe it has similar effect for glucose control, but I'm more interested in using berberine for an oral PCSK9 inhibitor effect. So until those studies are done, I'm probably just going to stick with the regular berberine. So somebody says, this all scares me. They're doing an intake at, looks like heartinfo.ca. So I actually had done a podcast with them about a month ago, and we talked about a lot of these tests. So it's one of the cases where, I look at it as, information is power. If you don't know what's going on and an event happens, that's a tragedy. If you have plaque in your arteries and you take steps to mitigate it, and the event happens, that's still unfortunate, but you at least have the power to try to tilt the odds in your favor. So it's one of those cases where test don't guess. You don't want to be a surprise, because half the time somebody has a heart attack, they had no symptoms before that heart attack happened. And they just took conventional testing where they just did a stress test or an EKG or an echocardiogram. They have no idea truly what the risk of a heart attack is. You have to know how healthy the endothelium is, and do you actually have plaque in the arteries? Can we reduce plaque? Yes, absolutely. First you got to stop doing damage. So often it's going to be a combination of lifestyle interventions, supplements, and medications. But three big buckets: you got to support nitric oxide if it's low. You have to lower inflammation, oxidative stress if it's high. And if you can't get your ApoB particles down with lifestyle alone or nutritional changes alone, then consider taking whatever agent you're willing to take. But the ones that have the most data behind it are going to be statins, PCSK9 inhibitors, ezetimibe, and then the new kid on the block, bempedoic acid. You have to lower the lipoproteins so you stop doing damage to the arteries. Then the plaque may regress. And I can tell you for sure it can happen. I've done it in myself even. All right, so this is not necessarily my area of expertise anymore. Somebody's asking about varicose veins. Is that a sign of possible vascular problems? Not necessarily. If you're somebody who's, over 20, 30 years old, then, if you've been standing for a significant period of time, then, the valves and the veins may tend to fail, and you may start developing some varicose veins. But it does not mean you necessarily have arterial disease. So most of the time it's more cosmetic in many people. Some people, their legs can ache or swell with it. Compression stockings are usually first-line therapy. Then you may want to talk to either an interventional cardiologist with expertise in this or a vascular surgeon. There are times they can use sclerotherapies, laser therapies. They can do other things to kind of get the varicose veins to shrink if need be. All right. Well, I'm pretty good with this timing, exactly 6:30. So every Monday, 6 p.m. Central Time, I come on here to answer your guys' questions. Your questions are very well researched and also very much helpful for other people who are seeking the same information. So these videos are always, saved. They're in my archives, so they'll be in my IG Live feed for a while. I always rip them down, and after a while, I get them all processed up. They go onto my YouTube channel, which is just drtwyman.tv. There's some longer form videos there as well that are on specific topics. There's a video that's going to be released that goes through just how I interpret my own labs. I'm going to update it in the near future as well. And then I teased at it. I did do a repeat clearly scan on myself. The saw plaque in my arteries were actually shrinking by 6% with no pharmaceutical agents on board. So I know it is possible. And I'll do a kind of a takedown of my clearly scan, but I'll probably release it on YouTube because then I can actually have it on the screen and have it as a better presentation than trying to use Instagram to present it. So appreciate your guys' time and attention and your questions. If you need anything in the interim, just drop me a comment, and I'll see you guys next week, Monday, 6 p.m. Central Time. Take care.